Okay, um, so what I'm going to talk about are issues to do with interpreting mortality impact of COVID-19. And this seminar has been put together very quickly. It's not a finished piece of work in any way, but it's trying to capture some of the things that I and other people have been doing. In particular, I've been working a lot with Vladimir Shkolnikov and Dima as well, and other people on some of these issues. So first of all, this is what we see in the UK every afternoon. This is the inside of Downing Street, and always stands in the middle. It used to be Boris Johnson, but this is the Foreign Secretary, someone called Dominic Raab. This is from yesterday. And on his left is the Chief Medical Officer, a guy called Chris Whitty. And on the right, interestingly enough, is the head of the British Armed Services. He's some military guy. So in a way, it feels like it's a wartime situation. That is certainly the way in which it's projected in the media in the UK. You will see these signs. Can you see my pointer? You see the cursor?
Yes, we can.
Yeah, okay. So you see this stay home, protect the NHS, which stands for the National Health Service, and save lives. So the whole push of government in terms of what's called the lockdown, the restriction on movement, closure of schools and everything, these are primarily motivated to stop the number of cases of COVID-19 getting to hospital, overwhelming the health service. There's a lot more I could say about this photograph, because the guy on the left, he comes from my institution. He's an outstanding infectious disease epidemiologist, but he's also the UK's chief medical officer. And he, together with others, has been very important in trying to introduce some elements of science into how the UK presents this. These programs are watched by very many millions of people. So they're a key way of the government communicating to the public what is going on. So the next slide is from yesterday's presentation that is shown to many millions of people. And on the horizontal axis is time from the 21st of March to the 23rd of April. And it shows the number of new cases in the UK that are diagnosed with COVID-19. Now, I'm not going to discuss very much about the trends that are seen. They obviously have gone up since March, but this is very, very difficult data to interpret, because as in every other countries, there have been quite substantial changes in the way in which testing is organized. And certainly compared to other countries, the UK has done very little testing of people other than in hospitals. So the vast majority of tests that have been completed are those which have been completed in hospitals. We've had a very low numbers of tests until recently conducted in, for example, care homes. Now in Russia, the care homes are not as familiar, but in the UK, amongst the elderly population, a very large fraction of people who are aged in their 80s and so on are actually living in institutions, not with their families. And of course, these are now major foci, major areas of the COVID pandemic, because once the infection goes into one of these care homes, it spreads very quickly through very vulnerable people. But so this doesn't really show the numbers of infections in the population at large, and it doesn't show the number of infections in care homes. So in some ways, it's a bit of a useless set of data in a way, and certainly is not comparable with other countries like Germany, for example, or Korea, or even the United States, where there's been much more testing done. So, of course, as I told you from the first slide, the emphasis of the government has been on saying we must protect hospitals from being overwhelmed. So one of the things that has happened is that new hospitals have been built. I think the same occurred in Russia, but a lot of routine hospital activity has been stopped. And that many of the facilities which would be used for other things have now become used for looking after people with COVID-19 infections who present with respiratory distress syndrome, which is actually very rather untypical of influenza-induced pneumonia. There's a very particular clinical presentation which requires hospitalization if it becomes serious. And this graph is one which is shown a lot. It shows that in some ways the UK, as countries like Italy and France and Spain, which have also had major outbreaks, they have been successful in reducing the number of people in hospital with COVID-19 from a peak in around about the 10th of April. So this means that there's now capacity in the health service, and that's been one of the objectives. Now, the other thing, these are all from things which are shown every single day in the UK. This is comparing deaths. So you can see in the middle, you can see the UK, and it says hospitals only. And you can see we're on the same sort of trajectory as Italy, but this is also a very useless comparison at in one level. First of all, it's cumulative numbers of deaths, and it just seems to show that the UK is going up and up and up. But it also, you know, the number of cases in the United States is much bigger than any other country, simply because it's a bigger country. So I don't need to tell this audience about how useless this is as a way of, in some way, communicating to the public what's going on. So what is getting to something which is a little more interesting is this. And this is a slide showing from March the 14th, the number of people dying in hospital who have been diagnosed with COVID-19 before they die. And you can see, this is from yesterday, so it shows, it goes up to the 23rd of April. And you can see there's undoubtedly quite a steep increase, and then a suggestion of a decline with big fluctuations up and down. It's a very uneven sort of graph with potentially a peak in April around here, but it certainly doesn't look very convincing in terms of being able to identify where the peak exists. And this is for a number of key reasons. So every day, the numbers of deaths that are announced, which go into the bar chart I've just shown you. First of all, as I've said, they're only deaths occurring in hospital. But they're not just deaths occurring in hospital, they're deaths amongst people who are defined as having tested positive at the time of death for COVID-19. And that will include an intensive care unit because they've had a car accident. And they actually, because there's so much infection in hospitals, they actually pick up the infection in hospitals. They may also pick up the infection from people who are treating them, nurses and doctors, who the estimates of the proportion of medical workers in different countries who are COVID-19 positive is very high. It's 10, 15% or more. So there's going to be transmission within hospitals. So some of the deaths are going to be to people who actually didn't have COVID-19 before they came into hospital. There are some other complexities which I'll talk about in a minute. Now, these deaths, interestingly, are reported through a completely separate system. They do not go through the Office for National Statistics, which is equivalent of Eurostat for you. They go directly from hospitals to the National Health Service. And to that extent, they do not require registration, civil registration, or any of the legal processes which are required before a death can actually be counted by the Office for National Statistics. There's an additional thing: the count of deaths reported to the National Health Service is for a 24-hour period up to 5 p.m. the previous day. And as I'm sure a number of you know, the real weakness of this is that this count given on any particular day includes deaths occurring over a wide range of previous days. And this is simply due to the inevitable delays that different hospitals have in reporting to the National Health Service. Some of this could be weekend effects, although these are relatively minor. Some of them are just due to the fact that some hospitals are operating under such pressure that all levels of staff are not able to necessarily keep up with what they're meant to be doing. So the issue of delays is absolutely central. Now, we've actually looked at this in some detail. This is the front page of an article which was submitted last Tuesday to medRxiv, which is not, as some of you will know, it is not actually a journal, it's a preprint server. And these are increasingly being used by scientists to actually bring their work to the attention of other scientists. So we intend to actually submit this to a journal later on, but the title of the article is "What Can Trends in Hospital Deaths from COVID-19 Tell Us About the Progress and Peak of the Pandemic Using Data from England?" Now, I think, unfortunately, this is still not available online because they have to check that it really is a true article and so on. But we're very happy to share this with anyone who wants a copy because it will, it's not been submitted for publication. Now, this is one of the key slides from the paper. It was produced by Vladimir Shkolnikov, and it shows for 4 just arbitrarily selected days, which are the 4th of April. So these are deaths on the 4th of April. These are deaths reported on the 4th of April by the government. These are reported on the 9th of April, the 14th of April, and the 19th. And what one sees is on the horizontal axis, date of death. And you can see very markedly for April the 4th, there was a big distribution of deaths reported on that day, going right back to deaths reported on the 17th of March, 2 weeks or more ago. Now, you can see this, the fact that it's a distribution for each of these days, but it's getting a little tighter, suggesting that the reporting delays are becoming less. But this actually introduces noise into the system and makes it difficult to actually see what the peak is. So the next slide, also done by Vladimir, is showing deaths reported to the NHS. It says DH for Department of Health, but it should be NHS, on between the 2nd of April and the 19th of April, according to the dates of death or date of announcement. So these dates here on the horizontal axis, they actually relate either to the blue, which is the date of announcement, or the red, which is actually when the death in fact occurred. And first of all, if we concentrate on the red line, we can actually see that although the decline here is in part, this part of the decline is because not all deaths have yet been reported. But up here, the numbers are going to be stable because a number of weeks have gone by. And you can see that there's clear evidence of a peak around the 8th of April. And this is being confirmed by many other groups. I think it's a very clear finding now that the 8th of April was the peak. But because of all the problems with the reporting, it looks as though the peak was in point of fact several days later, and also that it was closer to 880 deaths on the peak day compared to just over 800 if you do the analysis properly by the date of death. So these data, which are shown, they both, if you look here, you see it's quite jagged going down. So these deaths reported up to the 19th, it's not as convincing that there's a decline as shown by the date of death. And moreover, the actual peak looks as though it's here rather than where it really was. And it looks as though something like 80 or 100 deaths more were occurring at the peak of the epidemic of this first phase in England than actually occurred. So let's have a look at what one can do. So this article which we've submitted tries to shows those two previous graphs, but also looks at the issue of stratifying by periods of delay. So this is for all ages. And here we've just got the period, the 3rd of April to the 19th of April. These are dates of death. These are dates of death. And each line represents, so this bottom line here in blue represents those deaths reported, which actually the total number of deaths which were reported on consecutive days, which relate to each date of death, which were reported with 1 day's delay. Okay, so it's a relatively low number. It's something like between 100 and 130 at its peak. But these are the deaths which you would see after 1 day's delay for each day of death. And then you actually go up for 2 days of death. You see you don't have something on the 19th of April because these were deaths reported up to the 20th of April. So you don't actually see the deaths which with 2 or more days delay, but this is the cumulative number of deaths that are apparent with 2 days delay for each date of death. And then here's the same for 3 days and so on. And so as the days go by, it becomes the distance between the lines gets smaller as the cumulative total changes by a smaller degree each day. And it becomes very apparent that in point of fact, there was a peak on 8th of April. If I showed you this slide from a week ago, it would only go up to something like the 12th of April here. And some of these top lines would be missing, of course, but you would actually see that there was also evidence, a good evidence of a peak on the 8th of April as even early on. If you actually take, if you stratify by, if you look at the data stratified by period of occurrence. Now, this is the same graph as I showed you, which is the crude data, which is shown on a daily basis. And if we zoom in on this and we look at the deaths announced from the 4th to the 20th of April, which corresponds to the deaths occurring on the 3rd or earlier, but between the 3rd and the 19th of April, which is the graph I've just shown you, you can see that there's far less evidence of it. It's much less stable. And of course, yeah, you could say there looks as though there was a peak somewhere around here in April, but certainly it looks less convincing than, in point of fact, the smoother effect that you get when you stratify by period. So I think our recommendation has been in this article which we've submitted, is that essentially in the future more emphasis should be given to this sort of analysis, and maybe the public, the government should really just emphasize what's happening up to 5 days previously, because the more recent days are not really giving you the full picture. So this is an issue of how to better communicate to the public, and also to say to them, look, there was a peak emerging on the 8th of April, and that should have been communicated at an earlier date, in my view. Okay, so what we've also found, and this is something that other groups have not really focused upon, is that the peak, the trends and the peak vary by age. So what I showed you before with the 8th of April is actually a peak for all ages of death. This is what you see at age 80, deaths happening at age 80 years. And this age group is where numerically, the majority of deaths occur at age 80 plus in England, as they do in many other countries. And you see very clearly here the peak at the 8th of April. But what you see is there's actually, it becomes certainly up to here, and it's in point of fact, even if you looked at more recent data, it's plateaued. It's plateaued. There's less of an indication of a decline. Now, why might that be? Well, it's speculation at the moment, but there are data which are produced by other sources, including the Office for National Statistics, which are suggesting that there are increasing numbers of deaths occurring in care homes, homes for older people, and that these are potentially now, there's very serious cases from these care homes. Some of them are now being admitted to hospital. And perhaps although there was a decline, perhaps in the transmission of the disease some weeks back, because it takes on average something like 18 days between the decline in transmission and when you might actually see a decline in deaths, that may have been happening for people, older people living in the community, but the actual, any positive aspect of that from deaths in the community at the older ages are going to look as though they're offset by an increased number of people of age 80 plus who are being admitted to hospital with COVID-19 because of the care home epidemic having its own dynamic and only really becoming established several weeks after the community transmission became transmitted. Now, this is speculation. It's very difficult to get hold of any data by age on numbers of infections. This is a real failure in Britain of the public health system. The Public Health England, which has been given the responsibility for doing some of this work, has just not published openly any of the age-specific data. So this is speculation, but I suspect that it's something to do with the spillover from the care homes. Now, at younger ages, you actually see these are people dying age 40 to 59. And I just want to remind you that here, the top of the axis here is 450, whereas in this next graph, which is for the 40 to 59-year-olds, it's only 70 deaths at maximum. So here you actually have, in this age group where the numbers of deaths on a daily basis are relatively low compared to old ages, you do not see a peak at 18th on the 8th of April. You do not see the peak on the 8th of April. Instead, you actually see it on something like the 11th of April. Why the delay? Why the delay? Well, our interpretation is that younger people who are admitted to hospital in a serious condition, a much larger proportion of them are being admitted to critical care units because they actually will have come in, many of them, without having pre-existing disease, and they've got many more years ahead of them in principle. So there's going to be a triage effect whereby those who are actually are younger are more likely to be admitted. And this is evident in the following slides. So I need to explain to you what this slide is. So we've had in Britain for a number of years something called the Intensive Care National Audit and Research Centre, which produces periodic reports. But since the beginning of the epidemic, the pandemic has produced several reports where they've been able to separate those who are admitted to critical care, intensive care for COVID-19 compared to other conditions. It's called ICNARC is the system. And what I want to show you here in the first two data columns, these are cumulative data up to the 16th of April. This is a national system for the UK, excluding, I think, Northern Ireland. And what you see here is there have been something like 5,500 admissions to critical care units up to the 16th of April of people diagnosed with COVID-19. But the age distribution is quite remarkable. You actually see that only 3% of the admissions to critical care, okay? So you can be admitted to hospital, but you don't go to critical care. You can just be put on an infectious disease ward, but not actually go for advanced organ or respiratory support. So only 3% of these older people went, whereas 39% of those aged 40 to 59 ended up on a critical care unit, and 50% of those who are the next age group up. Now, if you look at the distribution of deaths, it's not dissimilar in critical care. It's not dissimilar to the number of people there. It's 7% of the deaths are in old age groups. They have poorer survival, but it by and large mirrors the distribution. But what is very remarkable is comparing the deaths in hospital as a whole, which will include these critical care deaths up to the 16th of April. And you see, as I've said before, the vast majority of these deaths are in older people, and only something like 8% of the deaths are in people who are aged 40 to 59. So you have this big discrepancy between people in hospital who are dying in hospital aged 80 plus at 6,400 compared to only 181 who actually were admitted to critical care. So the punchline here is that these younger age groups are more likely to get into critical care and have their deaths delayed. If they're going to die, they're going to have their deaths delayed on average by maybe 2, 3, 4 days. Hence this later peak that we see. Okay, and I want to move on to something else, which is excess deaths, which I think has been discussed previously. This is work, again, done with Vladimir and many other people. I just want to remind those of you who aren't familiar with the concepts of weekly excess deaths, the number of usually all-cause deaths observed in a week, minus the number of deaths expected based in that week, based on previous years. This is the basis for the Euromomo data, which was it's set up 6 years ago for monitoring influenza epidemics in 20 plus European countries. Unfortunately, they do not share the data. What they do is today they updated their website so it looks a bit better, and it's a useful place to go to get some data, but to get some impression of what's happening. And for countries like the UK, France, Italy, Spain, the Netherlands, and so on, it's very obvious that measured in terms of Z scores, which is how they present deviations in excess deaths on a weekly basis, that there has been a real increase in deaths. Now, what is the advantage of looking at weekly excess deaths as opposed to hospital deaths from COVID-19 or Office for National Statistics deaths from COVID-19 or whatever? It's because it's a directly comparable metric for international comparisons. It's because and this, I think, is going to become very important for assessing different national strategies and their effects. Because basically, if you're comparing all-cause deaths, in most countries, in all countries with complete vital registration, it doesn't depend upon the COVID-19 testing or treatment regimes. It's basically a standard metric. So that's its real advantage. But it provides, moreover, an indication of a net effect of the pandemic. In other words, the pandemic will have direct and indirect negative effects on mortality, plus some positive effects. So there's going to be a balance here. And I think, although the rest of what I'm going to say, it emphasizes the analysis of weekly all-cause excess deaths, there's also a role for looking at weekly excess deaths from specific causes of death. But that will only be possible maybe sometime in the early next year, because cause-specific data by week and so on is going to be much slower coming than is all-cause deaths. So this is just the beginning of a letter which was published a couple of days ago by The Lancet, which was written by me and Vladimir and a number of other colleagues. And it's basically making the case for the importance of weekly excess deaths. And the key paragraph here is, we therefore urge all national authorities who can collate counts and so on to place them in the public domain as quickly as possible, with maybe a 3 to 4 week delay. And these should be tabulations by sex, 5-year age group, and so on. Now, since we have been attempting to encourage different national statistics offices to do this, I think I believe that Eurostat has taken this case up and put an advisory notice to European countries that they, who are part of the European Union at least, that they should do this. And now we are seeing a number of countries putting these data online. Now, I want to mention here something which I'm sure most of you are aware of, is that Vladimir and Dima and many others are at the Max Planck involved in putting together, aggregating together these weekly data in something which is going to be called a short-term mortality fluctuations database. And I'm sure that that's going to be a very, very valuable resource. What I would say is that I think it's not going to be the only show in town. I think a lot of other people are doing this, but I think the Max Planck, with all its experience of doing the human mortality database and so on, will be in a very good position to produce a fantastically valuable resource. So just running through some of these negative effects of the pandemic on mortality and what we could expect to get out of analyses of this. So the direct effects on mortality are clearly premature mortality. People, I have friends in London who were perfectly fit, who were in their late 50s or early 60s, who have been in hospital, and if they hadn't been treated, they may well have died. They didn't go into intensive care. But this is premature mortality. People who, other than perhaps being in their 50s or 60s or 70s, were perfectly fit. Some of these people are dying. So that's premature mortality. And that applies to people in their 80s as well. People whose, in terms of their state of health, some of these people are dying because of the infection. But of course, there's an acceleration of the likelihood of death of those who are already very sick, whether they're just frail and very old, or maybe they've got cancer, or they've got dementia, or whatever, things which actually mean that physically these people are nearing the end of their lives anyway, and that COVID-19 infection basically accelerates their mortality. Now, one of the things that I want to talk about here is this. That shouldn't be there. Okay, so this is what comes from putting. I'm going to come back to that slide in a minute. So I just want to talk about harvesting effects. So this is an idea which will be very familiar to you all. This is from a nice paper, a very methodological paper looking at harvesting effects in the case of air pollution. So in other words, it's saying that, if you've got an acute insult like a sudden spike of air pollution, what it's going to do, it's going to influence the general population and the extent to which people actually it also is going to influence the risk of death amongst those who are already at risk. So people who've got respiratory diseases and so on, who are generally unwell, who with a spike of air pollution, or it could be heat. It could be due to sudden rise in temperatures in cities and so on, heat deaths, you get a harvesting effect. And the thing about harvesting effect, this is shown schematically here. This is the peak of when deaths are occurring amongst vulnerable people because of the insult, the pollution. But then as time goes by, there's actually then a recoil where basically mortality becomes less than expected, because some of the people who in general would have been dying in this later period, their death has been accelerated. And then you get back at a certain point to a more steady state mortality, which would have been witnessed before this insult. I think there's a big question about how big the harvesting effects are going to be. And what we could expect in terms of their impact on mortality after COVID-19 has subsided. How big those effects are going to be is unclear, I think, but that could be one of the things which might temporarily at least lead to, once the burden of directly occurring COVID-19 effects, infections, deaths from COVID-19 is gone, there may be a sort of decline, a rapid decline because of this harvesting effect. But we need to look at that and think how to deal with it. This is, I just put this up, it's from a paper published a couple of years ago or 18 months ago in the British Medical Journal. And it's showing an assumed kind of harvesting effect in some ways, although I don't think it's been demonstrated as such. But which is that even at the country level, countries which had, for example, a steep decline, not a steep decline, but declines in life expectancy measured on the x-axis. So these are all negative values between 2014 to 15. So all the countries to the left of this line had declines in life expectancy. In the following year, which is the vertical axis, a number of them had increases. Is this some kind of harvesting effect? It possibly is related to influenza, pandemics, and so on, but it could just be other influences. But this would suggest that there's an extended period of influence of a harvesting effect, which isn't just acute. So we need, I think, further work needs to be done on that to try and anticipate what we might expect to see. So here we are, negative effects of the pandemic on mortality, what I just showed you. But there's also an issue of people unwilling to attend emergency departments, for example, because they're afraid that they're going to actually get COVID-19. I just want to show you this earlier slide. This is up to, this is monthly admission attendance at emergency departments in England since August 2010. And you can actually see that in February and March, there was this huge fall. I haven't got the data for April, of course, but by all reports, there's been a huge fall in the number of people attending accident emergency departments because they're worried about getting COVID-19. And this is actually going to have an effect upon people's mortality and health. In addition to that, there's medium to longer term effects, cancellation of many routine and elective operations, postponing of chemotherapy and so on, which is widely reported. And I think there's a real concern that this is going to lead to increased mortality later on. There's going to be delayed diagnosis of cancer and other serious conditions. People who have sinister, worrying symptoms, but they are otherwise well, are now having diagnosis delayed. There's interruption in screening in asymptomatic individuals for cervical and breast cancer. And of course, there's something outside of the health service, which is there's evidence, certainly I think I've seen some evidence of increased alcohol consumption for Russia and for the UK. And of course, reduced levels of exercise with people being kept indoors. And these will have longer term effects. So there are also going to be damage to the economy, reduction in resources available for health and welfare services, which are not likely to have negative effects, and possibly increased deaths of despair, as they've been called, due to impoverishment and unemployment. So those are going to be medium to longer term effects. Positive effects, reduction in fatal transport and industrial injuries, which we'll probably be able to detect by looking at younger people, deaths in younger people under the age of 50 or 60. There will also be reduction in effects of air pollution. I'm a little bit of a skeptic about how real some of these reported effects of air pollution are, but that's likely to be something which we're going to have to take into account. So, finally, my final remark is this, is that I think in terms of the analysis of excess deaths, a lot of people are very keen to look at those countries which have had substantial COVID-19 outbreaks. That is the UK, that is going to be the United States, it's France, Spain, Italy, and so on. And it's going to be very important as soon as possible, hopefully in June or July, to be able to make some sense of the scale of excess mortality in these countries and the timing of peaks of excess mortality in relationship to saying something more definitive about the effectiveness of different strategies used in countries to deal with the epidemic. But there's also looking at countries which have not had a substantial COVID outbreak, but nevertheless, they had lockdown. They've cut back on hospital activity, health service activity. People have stopped, non-essential services have stopped, industries have stopped, and so on and so forth. And so these would include New Zealand, Australia, Norway, Czechia, a number of other places where really there's been a very serious lockdown, and yet there has been an outbreak. And this will tell us something about, it's a unique natural experiment, which will tell us about the impact of withdrawing routine hospital activity from the population and what impact that has on health and mortality. Okay, that's it. Thank you.